Welcome to Hand Surgery Resources YouTube video on Ehlers-Danlos Syndrome, with special attention to the upper extremity problems in Ehlers-Danlos Syndrome. This syndrome is a collection of heritable connective tissue disorders which appear clinically with varying degrees of skin hyperextensibility, joint hypermobility, and tissue fragility. The clinical features of Ehlers-Danlos Syndrome were first described by Edvard Ehlers, a Danish dermatologist, in 1901. And also described by Henri Danlos in 1908. These findings were consolidated into the concept of a syndrome in 1949. The name Ehlers-Danlos Syndrome has been used since then, and now many Ehlers-Danlos symptoms types have been described. In Ehlers-Danlos Syndrome, there are collagen defects seen in type 1, type 2, and type 5 collagen. These defects involve collagen structure, processing, folding, cross-linking, and microvasculature. Recent investigations have also shown defects in the extracellular matrix molecules like the proteoglycans and tenascin X. Ehlers-Danlos syndrome abnormalities involve protein trafficking, protein secretion, and protein assembly. All these abnormalities are caused by various gene mutations. These symptoms of Ehlers-Danlos syndrome include joint pain, sometimes with early onset osteoarthritis, joint hypermobility, joint instability, skin hyperextensibility, skin fragility, and easy bruising. In addition, these patients complain of muscle weakness, chest pain, palpitations, and fainting upon standing. Also, they report respiratory problems, GI complaints, spinal curvature problems, eye symptoms, depression, and anxiety. It is not infrequent that there is a positive family history for Ehlers-Danlos syndrome. Here we see the extreme PIP joint hyperextension caused by the joint hypermobility of classic Ehlers-Danlos syndrome. This drawing shows bilateral elbow hyperextension, which is so typical of patients with this syndrome. This drawing shows the Ehlers-Danlos syndrome patient's capacity to flex the wrist and extend and abduct the thumb to such an extent that the thumb can touch the palmar surface of the forearm. This is caused by the hypermobility of the joint seen in this syndrome. Here, the hypermobility is again demonstrated by the extraordinary hyperextension of the index ray, such that the patient can place the fingernail on top of the proximal dorsal wrist. This table shows the Brighton and Horan's hypermobility scoring system for Ehlers-Danlos syndrome patients. By assessing the passive dorsiflexion of the fifth finger, flexion of the thumb to the forearm, hyperextension of the elbows, hyperextension of the knees, and forward flexion of the trunk, a numeric value for the degree of hypermobility is obtained. The maximum score is 9, and a score greater than 4 is consistent with joint hypermobility as seen in Ehlers-Danlos syndrome. The skin hyperextensibility in Ehlers-Danlos syndrome is demonstrated in this drawing, which shows the hyperextensibility of the dorsal skin of the right hand at the wrist. Another component of the skin problem seen in Ehlers-Danlos syndrome is skin fragility, which is seen here as stria on the abdomen of this male patient. Other characteristics of ED syndrome skin problems include softness of the skin, a velvety, doughy texture, fragility, poor wound healing, easy bruising, and wide cigar-shaped atrophic scars. Other positive physical examination signs in Ehlers-Danlos syndrome include facial abnormalities, muscle hypotonia, scoliosis, eye problems like fragility of the sclera and blue sclera, vascular problems like aneurysms, respiratory symptoms, GI symptoms, recurrent joint dislocations and subluxations from trivial injuries, unstable pinch, and trigger fingers. In this movie, we see the unusual motion and swan neck deformities in an older individual with mild ED syndrome.
Here we see an older male with mild Ehlers-Danlos syndrome. Note the marked hyperextension of the PIP joint, the obvious swan neck deformities with retained flexion without PIP clicking.
The overall worldwide incidence of Ehlers-Danlos syndrome is 1 per 5,000 individuals. Classic ED syndrome occurs in 1 to 20,000 or 40,000 individuals. Hypermobile ED syndrome occurs in 1 to 5,000 to 1 in 20,000 individuals, while vascular ED syndrome is rare, occurring in 1 in 100,000 to 150,000 individuals. It should also be noted that 90% of the cases of Ehlers-Danlos syndrome are classic or hypermobility types, and less than 5% of the cases are vascular ED syndrome, while the other types are even more rare and more infrequent. The Mendelian inheritance pattern seen in Ehlers-Danlos syndrome include autosomal dominant, autosomal recessive, and X-linked inheritance patterns. The first classification syndrome for Ehlers-Danlos syndrome was developed in Berlin. This was followed later in 1997 in Villefranche meeting where the 6 classic major types of ED syndrome were defined. Presently, the International Ehlers-Danlos Syndrome Consortium, which met in 2017, has defined 13 clinical phenotypes and 19 causal gene mutations. This table identifies the majority of the Ehlers-Danlos syndrome's phenotypes currently recognized by the International Consortium Group. The table shows the clinical phenotypes which have been identified, the Mendelian inheritance patterns for each clinical phenotype, the gene mutations with the resultant protein abnormalities caused by these gene mutations. This is the second half of the table that demonstrates the current understanding of the classification for Ehlers-Danlos syndrome. The references for this classification table are shown here. Other diagnoses that are part of the differential diagnosis for Ehlers-Danlos syndrome are shown in this list. Some of these include benign joint hypermobility syndrome, osteogenesis imperfecta, skeletal dysplasias, Marfan syndrome, etc. When a patient presents, what are some of the signs and symptoms that mandate the need for a workup for Ehlers-Danlos syndrome? Well, some of these are walking late with extreme joint hypermobility, abnormal bruising and bleeding, unexplained vessel rupture or dissection, skin hyperextensibility, skin fragility, joint hypermobility with recurrent dislocations or subluxation, hollow organ ruptures, or arterial aneurysms. The diagnostic tools for an Ehlers-Danlos syndrome workup include skin biopsies, urinalysis, molecular analysis with genetic testing. Full-thickness skin biopsies can also provide tissue for electron microscopy. Collagen flowers, sometimes referred to as cauliflower deformities, are consistent with Ehlers-Danlos syndrome, although not specific. Tissue from skin biopsies can also be used for fibroblast tissue cultures, where abnormal types of collagen proteins can be obtained and identified by using biochemical analysis with gel electrophoresis. Urinalysis can identify increased ratios of urine LP to HP. A ratio of 6 or greater is consistent with kyphoscoliotic type Ehlers-Danlos syndrome. Finally, modern genetic testing can identify mutant genes that are associated with the various forms of EDS. This molecular testing can be done on specimens from tissue cultures or from whole blood. Here we see a next-generation genetic sequencing platform, which can be used to identify a panel of 12 genes associated with the various forms of Ehlers-Danlos syndrome. Other diagnostic tools that can frequently help include routine x-rays, particularly to rule out and evaluate secondary osteoarthritis, joint subluxation or dislocation, and ultrasound to evaluate various structures including organs without using invasive diagnostic tests which might be damaging to the fragile tissues and organs seen in ED syndrome patients. Treating Ehlers-Danlos syndrome demands a multidisciplinary approach. Pain should be controlled when necessary with medications that do not aggravate clotting and bleeding and avoid dependency. Therefore, acetaminophen, COX-1-sparing NSAIDs, neuropathic pain medications, and muscle relaxants should be considered. Physical therapy, occupational therapy, and hand therapy can help patients cope with many of the Ehlers-Danlos syndrome's problems. Further, patients must be advised to avoid contact sports because of the risk of severe injury from minor trauma. Intermittent use of steroid injections can be helpful. Cardiac evaluation is important, particularly in the cardiovalvular and vascular types of ED syndrome. Psychological support to help these patients cope with these devastating problems is very important and clearly indicated. Bracing can be very helpful in this group of patients. It helps reduce pain and control instability and the discomfort of arthritic joints while minimizing the need for pain medications. While limited surgical procedures like a trigger finger release can be helpful in patients with Ehlers-Danlos syndrome, in general, surgical procedures should be avoided whenever possible. Surgeons should remember the fragile nature of the tissues and skin. There should be a recognition of the poor and delayed wound healing and an understanding that the abnormal collagen of ligaments, tendons, and joint capsules may not provide good and enduring outcomes despite excellent surgical techniques. Other soft tissue surgical procedures that have been reported as useful occasionally in EDS patients include proximal carpectomy, ECRB tenodesis of the wrist, and both dorsal and palmar wrist capsulodeses. While soft tissue procedures might not provide predictable results in Ehlers-Danlos syndrome patients, arthrodeses may provide a more predictable long-term outcome because these procedures do not depend on strong soft tissue healing. Here we see the X-ray of an MP arthrodesis that was used to control a severe Z collapse of a thumb in a patient with Ehlers-Danlos syndrome. This X-ray represents a 10-year follow-up with a continued successful outcome. Other things to consider when looking at the need for surgical intervention include patients who present with aneurysms and pseudoaneurysms. Bowers and et al. Reported a compression of the median nerve secondary to a brachial artery pseudoaneurysm in an Ehlers-Danlos syndrome patient, which responded to resection of the aneurysm. Surgical complications that can occur with increased frequency in Ehlers-Danlos syndrome patients include tendon degeneration, tendon rupture, tendinopathy, osteoarthritis because of persistent joint laxity, swan neck finger deformities, excessive postoperative edema, blood vessel problems secondary to their fragility, excessive bleeding, delayed wound healing, and excessive scarring. Genetic counseling and genetic molecular testing should be considered for all patients with Ehlers-Danlos syndrome. Furthermore, screening of first and sometimes second-generation relatives should be considered. Finally, all patients should be checked for positive family history. Now that we have considered the sign, symptom, diagnostic tools, and treatment options for patients with Ehlers-Danlos syndrome, let's remember some of the key points. In classic EDS, in addition to the usual signs and symptoms, pseudotumors of the elbows and knees are frequently seen. Also recall that in EDS classic type, there are 150 known type 5 collagens that have been identified. In the classic-like Ehlers-Danlos syndrome, easy bruising is common, with hypermobility joints and skin hyperextensibility also being present. Cardiovalvular EDS is distinguished by a progressive cardiac valve disease and the need for routine echocardiograms and aortic root diameter measurements. Vascular Ehlers-Danlos syndrome is characterized by the easy bruising, lobless ears, thin, transparent, translucent skin, and arterial problems. 75% of these patients will experience a major complication, such as an arterial rupture, by age 40. Further key points include the fact that hypermobile EDS is unique because no genetic mutations have been identified for this type of Ehlers-Danlos syndrome. These patients also have considerable joint pain and demonstrate postural orthostatic tachycardia syndrome, so-called POTS. Kyphoscoliosis EDS is characterized by tissue fragility, severe muscle hypotonia, and scoliosis, which can be severe enough to cause respiratory compromise. Atherosclerotic EDS is caused by a collagen type 1 defect and is associated with very severe joint mobility. Bilateral congenital hip dislocations can be seen at birth. The dermatotypes is extremely rare, with short stature, short fingers, fragile lax skin, blue sclera, and hyperjoint mobility. Some final key points to keep in mind include avoiding surgical procedures and invasive endovascular procedures because of the tissue fragility. Obtaining an accurate diagnosis with molecular testing and genetic confirmation is very important. Providing genetic counseling and psychological support should always be considered. Thank you for watching our YouTube video from Hand Surgery Resource on Ehlers-Danlos Syndrome. For more information, log on to www.handsurgeryresource.org and explore Hand Surgery Source. Finally, don't forget to download our new Hand Surgery Source app at the App Store and at Google Play. Thank you for watching.